just to briefly introduce this discussion, it's a question that stimulated a lot of debate and public interest of late, and often around very high-profile cases that dramatise the moral questions, the rights and the responsibilities of individuals, families, professionals, society and the state. And I think often underpinning these moral questions and political questions is our own knowledge and understanding and experience of death and dying. How we understand the way that the line between an individual's struggle for life, their acceptance or even longing for death, how in real life that is often crossed backwards and forwards so many times depending on a person's state of mind. And we also know that now that when medical procedures are advanced so far, that often decisions have to be made when a person is not conscious, and therefore the responsibility is then passed from that person to their family and to professionals. So it's a very complex and a very compelling debate and argument, and we're going to hear 4 positions here this evening. And each of these speakers, who I'm going to introduce in a moment, is going to speak for 6 minutes. And there's lots of you here tonight, so as chair I want to listen to what they have to say, but I'd really like to get the argument and the discussion out there to the floor. We've got until around 8:45, so at the end of the debate I'm going to ask the 4 speakers just to come back and sum up. So we're going to kick off then, and I'm going to introduce the 4 speakers in the order in which they're going to speak. So first off will be Raymond Tallis. And Ray is a philosopher, a poet, novelist and cultural critic, and he was also until recently a physician and clinical scientist, and he's chair of healthcare professionals for assisted dying. Kevin Yuill is the author of Assisted Suicide, the humanist and liberal case against legislation, and he's also a historian and a lecturer in education and society at Sunderland University. And the third speaker is Lynn Hagger, and she is the author of A Good Death, Law and Ethics in Practice. And she's a lecturer in law at the University of Sheffield and a non-executive director on Leeds Teaching NHS Trust Board. And finally, Peter D. Williams is a speaker for Catholic Voices, a media speakers bureau that argues the Catholic Church's case in the public square. And he's a senior officer for the political lobby group Right to Life. So they're going to speak in that order. I'm going to let them get on with it. I think they're going to come up to the podium and do it. So let's get started.
Oh, thank you very much. Thank you for having me back to the Leeds Salon. Very much. It's great to be back. I've recognised this room from Aping Mankind a few years ago. Should we legalise assisted dying? This is a relevant issue because it is now going to be discussed in the House of Lords. Charlie Faulkner proposed a bill in May of this year, and it's going to have its second reading in May of next year. So we're not talking about something that is purely of theoretical interest. Physician-assisted dying is a law to permit mentally competent, terminally ill adults who are suffering unbearably as a result of a terminal illness to receive medical assistance to die at their considered and persistent request. It mustn't be confused with the broader concept of assisted suicide, when chronically ill or disabled people who are not terminally ill can be given help to end their lives. We're not talking about that tonight. Now, the case for, I'm going to say very briefly, the case against, perhaps I need to deal with in my 6 minutes at slightly greater length. The case for assisted dying is pretty straightforward. Unbearable suffering, prolonged by medical care, and inflicted on a dying patient who wishes to die is unequivocally a bad thing. And it follows from this that not doing or forbidding what has to be done to prevent this is unacceptable cruelty. There's also the question of respect for individual autonomy, the right to have your choices supported by others to determine your own best interests when you're of sound mind. This is a sovereign principle that applies throughout medicine. I was a doctor for 37 years. Nobody else's personal views should override this. Assisted dying has great support in the population at large, 82% of the overall population, 71% of those who have religious beliefs. And finally, the principle of compassion supports decriminalising assisted dying. It challenges the moral justification of allowing someone's suffering to persist unnecessarily at the end of life without assisted dying as a recourse. And as a doctor, in my 37 years as a doctor, I saw some pretty hellish suffering which was totally avoidable, and I felt very bad about the fact that I had to walk away from the patient. People have argued against assisted dying because they're worried about impact on others and on society as a whole. But also they've argued there's no need for assisted dying. If you have universally good palliative care, you won't need assisted dying. That's absolutely not the case. I've seen patients under my care, and I involved palliative care physicians of the highest standard who would have benefited from assisted dying. There's also the worry that if we have assisted dying, it won't develop palliative care further. And people have argued that that is actually not the case, and we can discuss that in great detail. There's also been the argument that if we have assisted dying, then the trust between patients and doctors and society would collapse. There's also been the argument that assisted dying, once you start, will inevitably be extended to people who aren't dying. It'll inevitably be extended to people who aren't dying and don't wish to die or can't express their wishes. It'll eventually become an obligation for all of us, and all of this is happening somewhere or other. It isn't happening somewhere or other, and we can discuss what's happening in other jurisdictions where assisted dying has been legalised. People sometimes worry that, and as a doctor I would worry about this, that we can sometimes get things wrong. Someone appears to be terminally ill and they turn out not to be terminally ill. But those who request assisted dying have a very advanced disease, a well-characterised illness, and in fact we doctors tend to overestimate prognosis. We tend to be much more cheerful than the reality that lies in front of us. But the fact remains is if you had a law legalising assisted dying, it would actually encourage doctors to review the patient in front of them and say, have we got this right? Are there symptoms we can control? Is the diagnosis right? And so on and so forth. There's also been a question that suggestion that assisting a patient to die would breach a doctor's professional codes. Well, actually, as a doctor, I felt I was breaching my professional code much more when I was walking away from a dying patient who wished for assistance to die than if I'd actually helped him to die, and we can discuss that, I trust. People said, well, you know, if you look at jurisdictions such as Oregon, only relatively few people avail themselves of assisted dying, perhaps 0.2% of those who die. Are we taking a sledgehammer to crack a nut? Are we taking this leap into the dark by legalising assisted dying when it only applies to a few people? Well, first of all, as a doctor, I feel actually a few people matter. Secondly, many more people benefit from the knowledge that there is a law supporting or decriminalising assisted dying than those who actually avail themselves of assistance to die. One figure from Oregon, for every person who takes the medication, 2 people have actually received it, but one of whom decides not to take it, and approximately 100 people discuss with their physicians whether it will not be a good idea. Many people have huge comfort from the assurance to know that they can get out of an unbearable situation if necessary. The current DPP guidelines basically are that there are certain conditions under which if you assist someone to die, this will be regarded as not malicious but compassionate. The trouble is no healthcare professional can get involved with assisted dying. So we have the grisly situation where assistance to die is actually carried out by one-off amateurs. So if Mrs. Tallis wants to help me to die, she will have to do it all by herself. It'll be up to her to check whether my carotid pulse has stopped. She will have to then face the police, who will then decide whether or not she's a criminal and whether or not she should face 14 years in jail for manslaughter.
Ray, 1 minute.
Thank you. Some people have said, well, over the years, haven't we had informal solutions? You know, doctors are sort of nudge, say no more, get on with it. The answer is it's no longer possible, and I'm rather glad it's no longer possible, because I think that is potentially a source of abuse, where people are actually bumped off without, as it were, the clear light of the law looking at what they're up to. End-of-life decision-making needs that clear light. At the present, such assisted dying that takes place in the context of a clinical, ethical and legal fudge, and I don't like it at all. By the way, the alternative to assisted dying are not particularly attractive. Death from dehydration or starvation, botched suicides, grim pilgrimages to Switzerland, or amateur assistance I've indicated with the threat of prosecution. So the case for legalising assisted dying is it would reduce suffering, it would respect people's choices, and it would also be a safeguard protecting patients. Thank you.
Right, my name's Kevin Yuill. I have to say I'm generally liberal on most questions. Just to introduce where I come from on this question, I support abortion rights for women, for instance. I would support stem cell research. I would support most liberal causes like that, fairly libertarian, I suppose, as well. My interest is as a historian. I studied the 1960s, where there was no campaign and euthanasia happened fairly regularly, informally. No one complained. Whereas suddenly in the 1970s, it was launched, a whole campaign was launched on the basis of bodily autonomy, and the question that we historians like to ask is, why now? And this has led me onto the whole assisted dying question. And my answer to should we legalize assisted dying is to say no. So the question, Ray has just had this up, so I don't even need to put this up. That's exactly the question that we need to have. And I think I've taken that directly from the same source as you have, Ray. So we can go on from there. But mentally competent, terminally ill adults, and I want you to think about the terminology here because I think it's important. To receive medical assistance to die, they're considered in persistent request. So the arguments against. First of all, I don't think the case for it is very good. When you leave aside the religious humanist bun fight, the name calling and the many emotional appeals, on both sides it has to be said, I don't think the case is very good. I think it's particularly poor, and I'll show you how. I also think, however, that it undermines fundamental principles, or threatens to undermine fundamental principles. I think one very important one is that human life is of equal worth, and that even lives constrained by disability and by horrendous disability have dignity and are worth preserving. That would be the first one. And second, that we all have a stake in the question of whether others live or die. The whole medicalization of assisted dying, or assisted suicide as I prefer to call it, is a real problem. It reduces what should be a profound question into a tick box exercise on a health form, as if it's a very, very simple choice that we tick one and choose that. And I think that's a bit problematic. So here are the problems with the case for. First of all, assisted dying, I object to the term. It's not a useful term that clarifies anything in English. It obscures the question of who actually accomplishes this. Is it suicide or is it euthanasia? It's suicide if somebody in Oregon sits in a room and ingests poison with a specific reason to kill themselves. I can't see that as anything else other than suicide. Of course, it's only called suicide if you go across the border in California and somebody with 5 months to live ingests poison, then it's called suicide. But when it's sanctioned by the state, it seems to be called assisted dying. I don't think the terminology is very helpful at all. Euthanasia is accomplished by usually a doctor, but suicide is accomplished by the patient. Let's call it what it is and avoid the sort of obscuring terms. Second thing, you usually have that scenario where there's somebody that is in profound pain and the medics look around helplessly and can do nothing. If we look at Oregon, it's not really about pain. As Linda Ganzini, who supports the legalization of assisted suicide, makes the point, it turns out that pain is kind of irrelevant. Loss of autonomy, loss of dignity, and less able to engage in activities making life enjoyable are the top 3 reasons. Pain doesn't even make the top 5 reasons for why people in Oregon, and go and have a look at these reports, they're fantastic, actually opt for an assisted suicide. We also have to ask, what is unbearable suffering? You can drive a coach and horses through that one. Who determines what unbearable suffering is? Very, very important questions, and yet ones that are not answered very well, particularly by Charlie Faulkner and his bill. We might say dignity and dignified death, and it's worth thinking what is actually meant by that. It is usually talked about in physical terms. I'd rather die than live like a disabled person. That may sound very, very harsh, but that is what it's talking about. It's defined in physical terms, and that is really what dignity and dying, as far as I can see, actually mean. Choice and autonomy. Now let's have a think about those. Choice and autonomy, of course we have a choice. Everybody in this room has a choice. Just about everybody who is determined to kill themselves can do it on their own. That's every single one of Dr. Kevorkian's patients had the motor ability to do this. Many, many people. It is possible to kill yourself if you have a will. So there's no necessity of assistance. You could also take the autonomy aspect very, very far, and you could say about the horrible case of German cannibalism that you might have remembered from a few years ago. If we say that it's autonomy, bodily autonomy, we really have to say that this consensual cannibalism was perfectly fine. If it's autonomy, I can't see that you have any basis to stop that sort of behavior. I'm taking this as far as it can go, of course. I'm pushing this as far as I can do. But any sort of consensual behavior, as long as the parties are all agreed, should be actually legal.
1 minute.
And compassion, to me, a compassionate response is not to agree with somebody when they say life is not worth living. Okay, very quickly, pay attention to the campaigns. Look what's happened where it has been legal, in the Low Countries in particular. And there you have an extension, a proposal to extend this to everybody over 70. And it's a very serious proposal. You'd think they'd all go home and say, we've legalized this, but instead they have out of free will, which is everybody over the age of 70. You have in Belgium the 33-year-old Ava with long-term depression. You have the 45-year-old twins who couldn't bear not to see each other again. This is what has happened in the Low Country. It hasn't happened in the United States. I think they need a profound culture change. But it's not like once it becomes legal, everybody goes home and says, great, it's legal. It extends to different categories. Conclusions. I think besides the case for the law, for changing the law is poor and based on emotive and false scenarios, legalizing assisted suicide will undermine the principle of the equal value of human life. There will always be individual cases, and I would never say that there are no individual cases whereby people are not deserving of an earlier death. I've had that in my own family. But I don't think you need to change the law. The present law is adequate to deal with those kind of situations. You won't find anybody languishing in prison for creating a true mercy killing in that situation, particularly physicians who are in the right position to do so. So to me, it's important to maintain a moral disapproval of the destruction of human life simply because I feel or you feel that is wretched. And that's what we are talking about. And such respect for human life is not restricted to those with religious values, but can extend to humanists like myself, and hopefully some of you as well. My book is far too expensive, by the way, so don't buy it. Yeah, steal it.
What royalties do you get?
Not a lot.
There will be a little bit of duplication, but I'm hoping I give him my arguments in support of legalising assisted death a slightly different emphasis. But I was quite pleased. I read a paper last week, an article in which the author was actually criticising panels such as this, saying that we should blush at the attention that we give this debate. You know, it can be a bit of a ping-pong match. And shame on us when the elderly, for example, who live in poverty and in loneliness, etc., fail to get the attention they deserve. And I think it's legitimate to have this debate. I think there's some very important values that do need debating. And I've argued elsewhere that at the same time, in parallel, there's a big job to be done to making it clear to the elderly, the infirm, whole range of vulnerable people that we value their lives and we try and make it better for them. And I think that would be part of a several-pronged attack from my point of view to avoid what is described as an invidious pressure put on the vulnerable to have an obligation to die. So I do think we do need to debate that, and I just want to reiterate the point about palliative care. No matter how good the palliative care, and I accept what has been said about the pain isn't always the key feature, it's the sort of indignities that upset people. But I think it's up to them to decide when life is not tolerable for them, what suffering means for them. It's for them to decide. So you can see that I do support the right of people to respect their autonomy, but also driven out of compassion and to help them to die. I think if we don't change things, at the moment we've got a two-tier system. I mean, this is just one fault. I mean, I don't have enough time to explore them all. But if you're healthy enough and wealthy enough, you obviously can travel to Switzerland, albeit ending your life perhaps prematurely in not ideal circumstances. But that leaves a whole lot of people who haven't got the help that they need not to be able to seek that way out. And for me, as an academic lawyer, that raises real issues of human rights and social solidarity. Now, one of the key arguments against legalising assisted death is the so-called slippery slope argument. And I do actually object to the term slippery. I don't think it's inevitable. And one of the things I'm exploring at the moment is drawing strengths from regulatory theory that could put adequate safeguards in place. Now, I'm not going to go into a huge amount of detail, and I'm not persuaded by the arguments from elsewhere, what's happened in other jurisdictions, because to me that just means the safeguards haven't been robust enough. They haven't been enforced at a sufficiently high level. And I think the data suggests to me, which is very equivocal, I have to say, is that there's no systemic risk necessarily, but there might be individual risks, and for that reason I would want some very robust systems in place. Now, regulatory theory has an awful lot to offer. It was born in economic theory, but there are some transferable ideas there, and some very good ideas on what good regulation looks like. So I would like a theoretical framework. I think we should draw from best practice from elsewhere and indeed within our domestic jurisdiction. I think we need to think about what sort of body could oversee such a system. Now, in something that I'm writing at the moment, I've had a look at the Care Quality Commission, and before you knock me down, I'm sure you will, clearly it's probably not a credible model, because it's come in for some severe criticism of its failings in the mid-staff scandal, for example. But it does intend to up its game. It is used to dealing with quality issues, and certainly being at the receiving end at the Leeds Hospital. People do not like the CQC coming in and flagging up failings on their website. So I don't think we should reject it as a model. My reasons perhaps for not supporting it in the long run would be because it's got too wide a remit already, and it still has a lot of credibility to gain. And I would support the Demos idea, Lord Faulkner's ideas, on having a purpose-built standalone body that just focuses on overseeing appropriate end-of-life care. And I have to say, I would like to see all forms of life-shortening interventions, and that's sort of omissions as well as positive acts, to be regulated. I'm not sure I share Ray's confidence in that it's not possible anymore to have some practice carrying on that's a little suspect, to say the least. I think we need some much brighter lines. And I think there's some very interesting models about whether we have peer review. We have some existing, sorry, slightly distracting noise there going on. We also have models such as the HFEA, the Human Fertilisation Embryology Authority, very used to dealing with very emotive topics. I mean, in this room, I'm sure there's a range of views about whether we should have embryo research, etc. So there's a lot to learn within our own jurisdiction. And I'm not sure how much time I've got left, but
You've got just now 1 minute.
oh, how amazing is that? I'd just like to finish off on the point about looking at the free will movement. You could also point to the Groningen protocol in the Netherlands, which allows the ending of neonates' lives. That is not necessarily the result of a slippery slope. I mean, there can be slopes, and they can just indicate that these are developments in ethical thinking. And the sort of regime that I would envisage would have very wide participation before who is allowed to die, who is helped to die, is actually expanded. So I'll finish there, I think. I probably haven't used my whole 6 minutes, but
We've got 30 seconds.
you can have 6.5. So
Professor
I'll finish there then.
Thank you very much.
Well, ladies and gentlemen, brothers and sisters in our common humanity, thank you very much for having me this evening. I'll be arguing, despite being taken as the token Catholic to a certain extent, I'll be actually arguing from a basic pro-life humanism. The pro-life case is not the same as a religious case, and so I won't be arguing religion tonight. If one of you wants to ask me a question on that, by all means, but I don't think the case against needs to be at all religious. It's entirely secular. I'll be arguing from a basic pure pro-life humanism that actually legalise assisted death, legalise assisted dying, retards palliative care, it corrupts medical culture, it corrupts general culture, and it endangers the vulnerable. I'm going to keep it very short because I only have 6 minutes. So, assisted death prevents its own obviation. Most people have talked about pain. Pain isn't the issue, as we've already heard. It's loss of mental ability or physical function. It's things like multiple sclerosis or Alzheimer's, motor neurone disease. Physical pain isn't the issue. It's emotional distress. It's existential pain that's mostly the issue. But if we are going to talk about pain, as long ago as 1986, the World Health Organization reported in cancer pain relief that 95% of cancer pain is controllable and the remaining 5% can be reduced to a tolerable level. And palliative care, is, of course, in the next 3 decades almost, has advanced greatly since then. But in Oregon, which is the model for bringing in assisted death in this country, 75.3% of people go for assisted death having had cancer. And 29.9% of those people, or people who give reasons for assisted death, do so because they feel they don't have competent pain management. What does that tell you about the development of palliative care in Oregon, I wonder? I mean, actually, Dr. Ellsworth, who was the former health minister and deputy prime minister who guided legislation of assisted death through the Dutch parliament, in an interview with Anne-Marie Tay, stated that legalised euthanasia had led to a severe decline in the quality of care for terminally ill patients in Holland, and that safeguards hadn't been sufficient. In London, within a 10-mile radius of Parliament, there are 6 hospices and 27 hospital palliative care teams within a 25-mile radius, including everywhere inside the M25. This number increases to 20 hospices and 58 palliative care teams. In the whole of Amsterdam, there's one hospice, the Hospice Curie. Again, what does that tell you about the development of palliative care in that country? And like in the UK, Dutch palliative care is not a clinical specialism. And in fact, there is no specialist knowledge and practice of palliative care in the palliative care teams that were developed in the late 1990s and early noughties. Of course, the funding for that has dried up. But in Oregon, we had the case of the 64-year-old Oregon woman, Barbara Wagner, whose lung cancer had been in remission. She learned the disease had returned and would likely kill her. And her last chance was a $4,000 a month drug her doctor had prescribed for her. But the insurance company refused to pay and instead said that she should have the assisted death itself, which the drugs for which only cost about $50. You might say, well, that couldn't happen here. We don't have a private healthcare system. But we do have a rationing system in our healthcare system. And that's why I think we should be very careful about the idea of introducing a system where people's lives could be judged based on how much they cost. In Holland in 2005, 500 patients were given a lethal injection without their request. And there's more involuntary euthanasia in Belgium. And in the June 2010 study of suicide euthanasia in Belgium examined 208 euthanasia deaths in the region of Flanders alone. The study found that 32% of those deaths were done without explicit request or consent, and the life-ending drugs were sometimes administered by nurses, not by doctors. This so they went outside the legal margins of their profession. There's a study from Belgium which showed that there was euthanasia possibly, I wouldn't say this is absolute, but it showed that organ donors, including 23.5% of all lung donors, had been euthanized, which raised concerns that patients were given an emotional inducement to be killed. In other words, believing that they would be better off helping us by being euthanized and then having their organs harvested. This is the kind of thing that corrupts medical culture, and I think it also corrupts general culture. When we look at Oregon again, in 1998, the year in which the Death with Dignity Act legalized assisted death in Oregon, 13% of patients applied for medication to commit suicide because they were frightened of being a burden on their families. Last year's 2012 report shows that had risen to 57.1%, more than 4 times the original number. Do we really want to live in a society which people are committing death partly because they feel they're a burden on other people? Is that really a humanist society? And this, I think, illustrates to a certain extent how the right to die often does become a duty to die. Can fear of being a burden really be regarded as making a voluntary, autonomous decision? Is that really autonomy? But it also corrupts general culture in a more wicked sense. I mean, I'll just quote Baroness Warnock, who said in her interview with Life and Work and Duty to Die, if you're demented, you're wasting people's lives, your family's lives, and you're wasting the resources of the National Health Service. She went on to say she thought such people had indeed a duty to die, and she said of advanced directives that I think that's the way the future will go. Putting it rather brutally, you'd be licensing people to put others down. All of these cases, I think, all of these examples give you a sense in which general culture and medical culture are fundamentally corrupted. The value of human lives are also, therefore, endangered, and particularly most vulnerable people. It's no surprise that leading disability rights organisations are very much against this. And I say this isn't due to religious reasons. Baroness Finney of Llandaff, Lord Carlisle of Berryhue, and Baroness Campbell of Surbiton, all of them are irreligious. Not one of them, in fact, Baroness Campbell, leading a disability rights campaigner, is an atheist. None of these people are religious. They're really concerned about public safety. And I think a truly humanist society, one that really cares about the dignity of human beings, is one which in fact protects and very much focuses on protecting most vulnerable people. I'll quote, to kind of paraphrase the Medical Ethics Committee of the House of Lords when they looked into this question, dying and the practice surrounding it is not an atomistically individualistic affair. It affects others in various ways that we can't always foresee. We can't separate the interests of the individual from the interests of society. And if we were to change the law in this area, I would suggest this would alter the medical and general culture in a regressive way that would harm especially the most vulnerable individuals. We have to work hard, I would say, as an alternative to this, to create a society that enables and cherishes the compassionate care, including the expansion of palliative care of the terminally ill, that thereby respects the true dignity of all human beings. And I think I'll stop there. Thank you.
Thanks very much to all the speakers. There's a lot of you out there, so I actually do want to go out, but I'd like to just give a few minutes to the speakers just to maybe come back on some of the issues that were raised. And I just wanted to sort of kick off with 1 or 2 questions of my own. I thought that Kevin, you raised something at the beginning of your presentation where you talked about there being a particular interest in this area today, public interest, and I just wondered if you wanted to say a little bit about, because I don't think you actually got to that, explained that, and why you think that as a society, politically, culturally, we're kind of more interested in this now than we were, say, in the 60s, right? And I don't know, while you're coming back on that, I know Ray wanted to raise some questions around the actual statistics.
No, just the sessions. Yep.
I'd like to come back with you, Ray, and say, you know, statistics aside, do you accept, I think it's this kind of idea of the corruption, which is what the point that was being made, and the opening the door and the slippery slope. And I think everyone's kind of acknowledged that that is actually what happens, and that there is an expansion. And so regardless of what's happening now and what the statistics are now, would you acknowledge then that it could go in that direction if society's values and changed, that you're opening the door to something? And finally, Lynn, I was very intrigued by something you said about the individual having the choice. And so the individual says, I actually feel that my life's not worth living as an individual, and I'm going to therefore request that I can have my life ended. And I thought that actually, you know, putting that onto the individual That seems to be one way of actually opening the door and the slippery slope in a way, because then we've got people who might feel depressed or might have a very subjective particular issue that they can't cope with. And if their individual voice is given that weight, then that's going to be pushing and pushing and pushing. So, Kevin, do you want to start? And I'll give everyone a chance just to come back, but I really want to get out there, so be quite quick with your answers, or anything else you want to respond to.
Okay, very, very brief history. Prior to the 1970s, you had the Voluntary Euthanasia Society in this country and the VSEA in the United States. And in the 1950s, for instance, the American organization could not afford to keep an office open and could only have a part-time worker. And this moved where it became a mass movement in the 1970s. This is what I found very, very interesting. And not only that, but you also had the challenge on the taboo of suicide occurring from about 1970. And this is what inspired me to sort of look at this and look at it critically and say, why was it at this stage that suddenly suicide was being reconsidered as a potentially legitimate activity on the part of an individual, whereas in the past it had been a taboo? Does that answer your question? They change names every once in a while, these organizations. So the VES is now Dignity and Dying in this country, and Compassion and Choices is the main one in the United States at the moment.
So it becomes a different kind of, is it got a different, sits somewhere else in politics?
It's very much, the Voluntary Euthanasia Society was a very elite kind of organization. It went very unpopular after what the Germans did during the Second World War, came out understandably. But what is very striking is the different basis of support. So from 1970, it was about bodily autonomy. It was about, I want to define myself and my own life. It's my life. I can do what I want with it. And that was very much the sentiment. Whereas prior to that, it was very much doctor knows best. A lot of medical people being involved with it. So that's essentially the difference.
Ray, do you want to come back on those?
I'm a doctor who over 37 years saw approximately 300,000 patients, and my whole central belief was patient knows best. So if the patient who is dying feels that there is absolutely nothing for them in continuing to live in circumstances they don't want, I have to listen and respect that. And it's not about pain. We can control pain. You control pain by making people unconscious. I know how to do that. But basically it's about when you're sitting in a heap of shit and urine and you're paralyzed and you've got nothing to face except another 2 or 3 weeks of utter, total degradation. That's what concerned me. That's what made me feel, as a doctor, utterly ashamed that I had to walk away from such patients. I felt ashamed as a doctor. So I don't have the distance of historian who can see it in the 1970s, 1980s. I had my face rubbed right up against this. And I have to say, there were so many wrong facts I heard from the opposition that I have to ration myself. First of all, assisted dying is not about shooting people who are disabled. I, as a doctor, was responsible for the government's policy on stroke, people who are disabled. I have fought for disabled people all my life. I've fought for older people. I was professor of geriatric medicine. It's not about that. It's about respecting the wishes of people who are terminally ill, for whom the only prospect is death, and the question is whether you die now or after 3 weeks of utterly degrading misery. It's actually false what you said, and you should be ashamed of it, what you said about the situation in Netherlands. In Netherlands they have fantastic palliative care because it's not concentrated in particular consultants, it's disseminated. All GPs have to be trained in palliative care. And finally, I could go on, but you'll be able to breathe. In Oregon, ladies and gentlemen, basically they're not standing up and shooting older people. 0.2% of people who die avail themselves of assisted dying. 0.2% of those who die. A small proportion, double that, will actually take a prescription, but they won't use it. and 100 times that will discuss it with their doctors and know with great relief that they can that they may well avail themselves if they need it. So I have to say I'm very sorry at some of the wrong facts you've heard, because you've been counter and uneducated as a result of some of the presentations.
Ray, though, I'm going to come, but Lynn, I'll come to you with that, because I think some of
Should we
the
have a right to reply as well?
some of the question I had though was about this opening the door. Now you've said that a very small number of people avail of this, and so when you open the door, more might. And I was thinking
But
of
that
the
metaphor is not a good one.
going back to you, Lynn, about this question of the individual. Now, the individual who is in distress, who's depressed, who's isolated, who's lonely, who maybe has no family to visit them. And we do know there's a crisis of care in many of our hospitals where people aren't getting properly looked after, we've heard, and are they not the people who would be, in a sense, in line for this?
Well, that's why I prefaced what I was saying with the fact that we need parallel activity going on to make sure that people don't lead such distressing lives. And I think part of my safeguarding sort of regimes I envisage being in place would work through these issues with that individual and actually address the issues with those individuals. I mean, at the moment in the DPP guidelines, people have to express settled wishes. Now, clearly that's a movable feast, what we mean by settled, but I think you would need a lot of in-depth exploration about what you can do with that individual. But ultimately, I'm very persuaded by the sort of scenario that Ray has portrayed, and really, you know, what would really count above all else is what that individual's take is on the indignities that they're having to suffer.
And the indignities you would see as it's their problem, an individual problem, which they could resolve.
Well,
themselves.
I've seen some discussions where, just one example, where healthcare professionals, and I'm sure Ray has probably come across this, or where people actually express that they feel very embarrassed by being incontinent and all those sorts of issues, and the healthcare professional very kindly saying, oh, don't be so, it's, you know, it's nothing, we see this all the time. Mm-hmm. That actually doesn't help some of those individuals. They do not want, you know, for somebody who has, you know, led a very controlled life, and I mean, these things matter more to some people than to others. But for some, I think it's just a step too far to have to suffer that.
I'm just going to ask one question of you then, Peter, because your difference to me seems to be around that you're looking at it from the individual perspective, and Peter, you're taking a social view. You're saying that this is it's not an individual's question at all.
We see the individual in the context of the social. We're none of us, you know, to use the cliche, we're not none of us islands. But this is the central point that I'll quote. The Archbishop of Canterbury. I didn't want to make this again religious, but the freedom of one person to utilise in full consciousness a legal provision for assisted suicide brings with it a risk to the freedom of others not to be manipulated or harassed or simply demoralised when in a weakened condition. Once the possibility is there, it will not only be utilised by the smallish number of high-profile hard cases, in our case to make bad law, but will also create an ethical framework in which the worthwhileness of some lives is undermined by the legal expression of what feels like public impatience with protracted dying and unproductive lives. I think that cuts to the very core of this problem. That yes, there is a kind of ethic of autonomy clashing against an ethic of community here. But actually, when we do cherish the community, when we do cherish the laws that make up the common good of society, those things that directly impact the individual. So I don't believe in this strict dichotomy here between the individual and the social. The two are fundamentally interlinked. When you damage the social, you damage the individual. And many more individuals, I would suggest, are going to be damaged by the idea of legalising assisted death who would be helped by it. And we don't live in a perfect world. We don't live in a society that can be utopian. And this is, again, I think a dynamic in this debate is utopian thinking coming up against the law of unintended consequences. When you do something, even if you do want to help these small group of hard cases, you find all these unintended consequences follow that actually damage many more people's lives. So this cuts to the very core of this whole debate.
And that's an empirical claim that hasn't been worked out in other jurisdictions. Okay. And it seems to me that this dichotomy between the idea that you respond to the need of a small number of individuals, and I as a doctor desperately wanted to. I'm sorry to say I'm going to use the fact that I was a doctor, and I'm much closer to all this than most of the people on the panel. And the response to that did not in any way degrade my attitude towards people with stroke, with arthritis, with all sorts of disabilities. I fought very hard for those people as well. And in fact, if you read my NHS SOS, you'll know how I despise the Tory government for shafting the health service that actually will support our people
But
with
that
disabilities.
only tells us about you. It doesn't tell us about a lot of more less scrupulous people. And by the way, that the
I don't
innovation
think I'm
work-
different from others. I don't think I'm a saint.
Well, no, I don't.
I think I'm pretty normal as
I
a
think
doctor.
people are quite diverse, and you have to make sure the law exists not because most people are saints, but because some people are actually quite deeply wrong-headed and will act in very unscrupulous ways. And by the way, when I mentioned the bit about the Netherlands and its palliative care, that comes from Baroness Finley of Landau, who is an expert in palliative care.
And I challenged
So
Baroness Finley,
I trust
and
what she has to
She
say.
apologised. She actually gave a meeting to lay people, and she said there was no palliative care in the Netherlands. And I approached her after and said, "That's not true, Ilora." And she actually then said, "I'm sorry."
Right.
You're
What I
right.
said was not there's no
I'm
palliative care, but it's
I'm
nowhere
going to
near
jump
what we
in
have
here
in
now.
this
It's
country.
much better than ours.
I'm going to ask.
Yeah.
I'm going to ask for some questions, and I'm going to ask the audience for some questions. Kevin here wants to put a question in as well. So can I just gather up, say 4 or 5 questions, and then put them back to the panel?
Can I ask it now?
And you can ask yours. You can be the first one, and then we're going out.
Okay, my question is, if this is all about patient-centered rights, if this is all about autonomy, how do people distinguish between a 21-year-old lovelorn suicide case, somebody who wants to commit suicide, who feels that they're suffering unbearably, who is 21 years old, and somebody who is in the very last stages of cancer and is in their 80s? If it's based on the patient wishes, then you have to accept either patient wishes. That is what autonomy is. So I wonder how you would sort of deal with that. I think the problem is that either you offer an assistant for suicide for everybody, and therefore the proverbial man on the bridge we need to give a push to, or you say, oh no, only you get assisted suicide, you people over here, we're going to rope you off from the rest of humanity and say your lives are not worth living. And that's essentially what it is. And that's my question to the other two.
Okay, that's
And there's
one
an answer to
question.
that.
Well, you're not going to hear it yet. We will. We have to hold on because I'm going to take some more. Just people put their hands up. There's a gentleman there, and there's another hand there. So let's have your question.
You say the politics of ethical issues is never clear cut. That's one of the real problems. And those who put forward the bill and the idea are certainly principled, and the aim is admirable. My concern as a politician is whether bringing the bureaucracy of legislation into this will achieve what is the aim of the legislation. Once it's taken away from the emotion of it and it's brought into rules and regulations, will it actually do what is intended? And I have some doubts that it will. Many years ago, a colleague on the council who was a much respected local GP and long standing in the community. And he said to me at the time, the broad risk of euthanasia, we said, look, never try to legislate because it will cut down the amount we do. And I am not going to see my patients I've looked after for 30 years suffer at the end. Never try to legislate. And I've always borne that in mind. I'm persuadable, but I'm not yet convinced.
Thank you. Thanks. And there's another point over there. Yeah.
Yeah. Would not a living will be an answer to the problem for the whole issue? And I'm also Catholic. I'm also Green Party, which is not a contradiction to me. But as looking at this, and I knew someone who had a living will, and they went into hospital, and his wife went into the hospital and said, please take my husband off that machine, there's a living will, and he was allowed to die. And I remember thinking at that time that it was right.
Thanks. Is there any more questions? Yeah.
I suppose it's mainly to Lynn, but it's about feeling as if you're a burden, and I wonder if that could ever be a valid reason to help somebody with assisted suicide, and how the panel that you propose, this regulatory body, might respond to somebody who says, I feel like a burden, and meets all the other conditions, but I want to be helped to die.
Thanks. And there's one here and one at the back there. So I'll take yours and then come to you.
Yeah, I've got 2 brief questions. You mentioned that well, we wrote in the blurb why is this a debate today, and what you've Kevin, you've raised, which Pauline alluded to, is more why did it begin as a debate in the 1970s? You kind of historically said how that happened, but you haven't said why, really, that this became a debate in the 1970s. Why are we discussing this today, really, as an issue? Why is it, what's changed? Why is it an issue at all? I want to say, why legislate and regulate something that has been done informally? Why invite the state into this process? May it not prolong suffering? Most people in hospital die from the morphine overdose that kills the pain at the end of the life when you're on cancer. And by having to tick boxes and fill in forms and consult, may not this actually prolong suffering where normally it wouldn't?
Thanks. And there's one last one, and we'll come back out again, but that lady there, yeah.
One of the reasons why this subject is coming up so much now is that the baby boom generation post-war has lived through seeing their parents die.
Yeah.
And we have seen how horrible that has been. And we've also faced the issues with how the medical profession react to it in the current climate. And the medical profession is scared. It's scared of being reported upon, even if the family seems to be in agreement to do nothing. So my 89-year-old father was uselessly shipped off to a hospital for his last week. I was just so relieved they sent him home, so he actually died in his own bed. But there comes a point when we're losing family doctors. That whole meaning that I grew up with when I was young, that you had a family doctor who knew the family and could help. We have people on rotas, strangers to the family, who can't assess the situation in any real way. And they will feel they have to send people into hospital regardless of the situation. When my mother was chronically ill, going into hospital, I had to fight like blazes with the hospital to recognise that although she had chronic factors, she was suffering an acute situation. There were a number of times when that was very difficult to achieve. When she was clearly at the end of life, practically totally losing her swallow, when I was saying when she was admitted, don't resuscitate, I had about 3 different doctors call me out of A&E to say, did you really say this? Did you really say this? They're just so frightened. And at the end of the day, I think one doctor, prompted by one of the speech therapists, had more or less said, well, your mother, maybe we need to think about, the end of your life. And then that seemed to fade away. I resisted it at that time because I didn't agree at that time. A few weeks later on, I'm having to almost prompt the consultant and say, what are you intending to do with my mother? This is what I see is happening between the hospital and when you've got her on a drip and when you take her off the drip. So the medical profession is so scared of the situation. And people like myself are trying to get clarity, caring for our family, wanting comfortable deaths for them. It's never easy, but you want the most comfortable death you can. And you certainly want a comfortable death for yourself. And that's where the push is coming. From us who've seen what it's like now.
Okay, thank you. I'm going to come back to the speakers here because I think there's some really interesting strands here. And the first question that Kevin raised was about distinguishing between the 21-year-old lovelorn, depressed person and the very old person who's reaching naturally the end of their life. And do we distinguish between their individual desires? And if you say assisted suicide for one, then why not for all? I think also, though, around this whole question of why now, why are we thinking and worrying and anxious about this now? I think there's some really interesting questions coming up from the floor. And I think that this idea that was raised at the front here about, the informal methods that might have been, and I wanted to ask you this, Ray, as a doctor. in the past, or what happens now? I mean, we don't have legislation that permits this, so I'm assuming that what happens now, because I'm not assuming, I know from experience, that what happens now is that people do make decisions about whether to extend life, whether to continue with care, whether to withdraw care, whether to treat, and so on. So people do make these decisions, and they always have done. Why are we more anxious about those decisions now? Is it to do with what that lady was saying, a kind of lack of trust? The way that we don't have the family doctor, we don't have that continuous kind of relationship. Is there something happening out there, politically, socially, that's changing the way we think about this? So,
Sorry.
yeah, do you want to come back on?
Not necessarily in the order you want,
Not
but
necessarily
bring me back.
Any
but
order you want.
it's
yeah.
just that it seems to me that the change is multifactorial. I accept some of the reasons that have been given, but the other thing that's going on is that, of course, we're all living very much longer, but not necessarily with a fantastic quality of life. So I think we're facing that sort of thing as well. And I think you talked about our relationship with healthcare professionals. Well, I think the scandals that we've had in recent times have actually undermined that relationship. And perhaps we don't trust our doctors in the way that we used to. Particularly if you don't have that long-term, ongoing personal relationship that Ray has clearly enjoyed with his patients.
Would you agree with that comment, that actually the bureaucracy may not actually help? That introducing more regulation might not actually help to rebuild the trust?
Well, of course, the limited amount of time, I couldn't really tease out the detail of all of this, but I would be appalled actually. I hate bureaucracy, but I do see the need for regulation, and I'm very alarmed at what I think is being described by the gentleman on the second row, is carrying on with the status quo, bit of fudging, the double effect doctrine where you could administer a little bit of extra morphine and it'll ease the passing of someone. There was a study done in 2009, I'm not aware of a more recent one, where I think 900 doctors admitted that they'd unlawfully ended somebody's life. That worries me. I want things to be much more transparent. And the sort of system I see it operating pretty much as it does now, perhaps multidisciplinary assessment over a decent amount of time, so you thoroughly explore all the issues and what can be offered to that patient. Where there's a dispute, I would see it perhaps moving on to another level. I haven't quite thought what that might be, but we have models of clinical ethics committees, for example, in most hospitals now. I've sat on one. We've helped healthcare teams who can't reach agreement with families, or indeed between themselves, with the difficult decisions. The sort of overarching regulatory body along the lines of something like the CQC, HFEA type model, is overseeing the whole process, not another layer that you have to go to in each individual case. So they would just check that there's good practice by having ad hoc inspections. The organisation or the hospital have to report to that body. There's all sorts of mechanisms, and I don't want to bore people to death with it, but I don't see it slowing down the process. I think that would be extremely unhelpful.
Can I respond to the bridge, bureaucracy and living wills?
Yeah.
First of all, a living will, you cannot requisition positive treatment. You can only say what you don't want, and you certainly can't requisition treatment that is illegal. So there's no way a living will, you can say, I wish to have assisted dying. You can't. So that's, unfortunately, living wills, although please have a living will. Compassion in dying, you can download one, a living will, but that's a little sort of plug. Secondly, about bureaucratic. Yes, to my shame, when the Royal College of Physicians was invited to respond to the first Joffrey bill, I was the chair of the ethics committee 10 years ago, and I said the last thing we want around the bedside is a bloody judge. I can't tell you how stupid I feel in retrospect of that. The answer is, of course, it's going to may become a little bit more bureaucratic, but in the current context, you can't do it by a nudge and a wink. You simply cannot. The world has moved on. We don't like it, I don't like it, you don't like it, but the fact remains is we do need a bit of bureaucracy. How does it work? It actually works in practice quite well in Oregon. So the bureaucracy doesn't actually prevent people from getting the kind of relief they need. And finally, Kevin, I may as well advertise my book, Reflections of Metaphysical Flaneur, deals entirely with your man on the bridge case. It seems to me whenever we have a principle, such as autonomy, we can't always apply it absolutely. We don't have second-order principles to tell us when we should deviate from principles. Let me give you an example. I support abortion, as Kevin does, but I'm actually against aborting women at 39 weeks. Why am I against aborting women at 39 weeks? What's the difference between 39 weeks, 24 weeks and 14 weeks? There's a continuum. And the answer is we have to dichotomize across a continuum. And that's everywhere present, whether it's the age of criminal responsibility, whether it's free speech versus hate speech, whether it's appropriate abortion. So I have to say that Kevin's killer argument, basically about the man on the bridge, would apply to abortion, it would apply to the age of criminal responsibility, it would apply to every single secular principle. The only character who has principles that cannot be, as it were, nuanced will be Peter at the end. Basically, and there's an absolute principle, thou shalt not kill. Oh, by the way, it's okay to bomb people you don't like, but leave it on the side. The just war and all that.
That rather presupposes my views on bombing, and it's thou shalt not murder, not thou shalt not kill. Those who are receiving the bombs can't tell the difference. Yeah. But there is a distinction we can make, and I think it's a very rational one. But we don't want to get grounded into that. Can I just ask by all means, I was just going to ask, when you were talking about people dying from morphine, were you saying, talking about deliberate doctor euthanasia outside the law, or were you talking about people just die anyway because of morphine?
No, I mean, the way my mum died, who died of cancer in a hospice, was at a certain point the doctors said to all the family, you need to come in now and see her. And we all knew what was going to happen. You know, she was in such pain, she was right at the end, that the dose of morphine we would give her would end her life. And that's how lots of life ends. And that's kind of humane, and it's the way it's done. It's
but he was a very lucky doctor. He could have been, doctor kills my mother. Daily Mail headlines, 400,000 people have been killed according to the Daily Mail on the,
Yeah, well, from what I've been told about palliative care, the whole idea is that the pain threshold is here, the level of toxicity that kills you is here, and the aim is to get it in between those 2 points. So you're not supposed to use morphine to kill a patient. So that's why I wanted to clarify, just because that's not the way I don't think it should be done or supposed to be done. That's why I was questioning about that. In any case, but with regards, I mean, we talked about people wanting this because they've seen their loved ones die in pain. I wonder if that's due to a lack of palliative care. I don't know the lady's individual situation like this, so I can't judge. I think one of the problems with the whole idea of safeguards, whether or not you have a kind of CQC system or not, is that you're putting doctors at the very heart of the assessment process. It's interesting to me that in Oregon, the median relationship range in terms of weeks of patients and their doctors was last year 19 weeks. Over the last 1998 to 2011, it was 12. And we know that doctors, of course, don't see their patients all the time. They don't know them very much outside the context of the consulting room. I certainly don't know my GP very much at all in general. So can they really judge the situation of an individual patient who comes to them asking for assisted death? I really question that. And it seems to me that the whole idea of legalising and licensing assisted death assumes too many sort of ideal conditions. This is what I mean about utopian thinking. The patient knows firmly what they want, whereas many are very ambivalent about what they want. They're quite unsure and fearful about the future.
Law includes something in relation to that, but perhaps we can discuss that.
We also, and we also assume, for example, things like that they have loving families. I mean, most families are loving, but again, the law doesn't exist because we're all saints. It exists because some of us are quite unscrupulous. So I don't know how you manage within these safeguards, even as they're being proposed right now, to deal with these kinds of issues. It seems to me that there are too many factors that you can't really deal with. And that endangers, again, the lives of very vulnerable people.
We turn people off ventilators at the moment.
Allowing people to die and euthanizing them is two different things, though.
But
we allow people
your anxiety about families saying, please turn my mother off the ventilator because I want to inherit.
No. Peter, do you actually, because I thought that the point that was made here, that Paul made, is actually something that in our sort of common sense, we're actually quite familiar with this idea that there comes a point in the treatment of someone when they're very, very sick, where doctors do invite the families. I know that's what they do, and they say to families, look, we can go on treating this, or we can ease off, and they'll just drift off, they'll just
Let
go.
nature take its course.
Yeah, nature will take its course. And often we're not talking about highly technical life support machines. You're actually talking about treatment that can help prolong someone's life. It happens now in a kind of informal, if you like. When I say informal, it happens through people making decisions and consent over and over again and coming back to the question.
When nature doesn't take its course, when nature takes a horrible course.
I'm going to come out in a moment,
Yeah,
Let me
well,
come in on
exactly.
that.
When
Okay.
after all, okay.
Kevin,
Okay.
do you want to come in on that?
Yes,
And
'cause
then we'll
I
go
think
back
by all
out
means,
again. Yeah.
It's a fascinating question, but I think I have had a very similar situation to you, where actually we did a vote, which was a little bit odd, but
That's
it
the
was,
American system.
yes, perhaps it was well, Canadian.
Canadian,
That's
yeah.
But I thought it was a very interesting, and I suspect many people have this situation, and in fact, this has been okayed by various different authorities throughout the night. Touching on the historical question, Pope Leo XIII. With an encyclical, am I getting that
Yep.
right? Sorry, I'm not a Catholic, but
Would be Leo the Lion, would it?
and he made he okayed the double effect in from the question from an anaesthetist: is it okay to give enough morphine that with the purpose of killing the pain, but it actually has the effect of killing the patients?
Yeah.
He okayed this. This went on a lot more than actually it does today, because people tend to favor terminal when they just put them to
Sedation.
sleep. Terminal
Sedation.
sedation, yes. Terminal sedation seems to be the thing that many people do. So there's less and less of a demand upon it. This is what the interesting aspect is. There was more of a demand upon it in the 1960s. Just to touch on the sort of authority aspect, which I think is very, very interesting. The lady at the back, her comments were very apposite here, in that doctors used to take control of situations. They used to say, this is what's going to happen. I have decided that this is the right thing to happen, and often they would okay it with the family, but they would take responsibility in that particular situation. And one of the disturbing aspects about this whole proposition is that it's bringing the state to that deathbed scene
That is
and
nonsense.
regulating
That
it.
is
Oh no,
absolute
it's
nonsense.
not nonsense, Ray,
It is
because
the
that is
doctor-
what
it's
you're
the doctor
proposing.
with- the
That's
doctor
what
with
Charlie
disca-
Faulkner is
No, it's in
proposing.
the state.
He is
It's-
saying we're going to regulate a process
It
that
is
has
creating
been
a
up
new
until now
context in which
in a
medicine-
private sphere, and suddenly we're going to shine our spotlight. I mean, I didn't become an atheist to kick out the priest from the dying scene and invite in a lawyer. I don't think that's
Well,
necessarily a very
that was
good
my
idea.
ill-informed response when we first discussed the Joffrey
And I
bill
think
10 years ago.
your ill-informed response was absolutely right.
was
Why
not
should
enough.
we have the state into bringing it into the deathbed scene? The deathbed
Essentially-
scene has always been something
Essentially,
separate
it adds
from
a
the medical
further
sphere.
possibility in end-of-life care, which clearly the doctor, the patient is central, the doctor is next to the patient, and the family is also involved. It adds an extra possibility. It isn't about, as I ignorantly said in my first response, and I feel very ashamed about it, let's not, having a judge around the bedside. I feel so embarrassed about that kind of
I don't
response.
want one.
It's an extra layer of protection, and I think one of the
Yeah.
assumptions being made here is that it's one doctor's decision. I wouldn't want that system. I think
It's
it should be a
two
multidisciplinary
Yeah, because that
approach
worked so well with the Abortion
involving
Act,
the
didn't
family.
it?
Well, no, we're imagining that doctors are Mengele's. I think most doctors have a patient's best interests at heart, and they will take the right action. I want to be able to look into my doctor's eye and say, when the time comes, if it's right to do it, you go ahead and do it. You take responsibility. You will have a better idea of
I
the
think a
time
lot of
because you will
modern doctors
understand the
actually
prognosis
feel
much more.
uncomfortable with having that level of responsibility.
Well, they did in the
Prefer-
1960s. So this is one of the historical questions we need to ask: what
When-
has changed
Yeah.
now?
When we had the debate about the abortion in the 1960s, we were told, this won't lead to lots and lots of abortions, only happen in a very narrow number of cases. We now have around 200,000, 180 to 200,000 abortions per year, precisely on this mechanism of having the two doctors sign it. And we know, of course, in recent investigations, the doctor sometimes just pre-sign forms and just goes ahead like that. So is this is a safeguard, really? Have we learned nothing from the last 40 years? This is not good.
But
Just
this
isn't
is
good enough.
exactly that's such a useful statement to make, because if you look at the trajectory of abortion, it shot up to about 180,000 a year within a few years. What's happened in Oregon, it's remained at 0.2% of deaths. So you haven't had the same trajectory.
Well, that's comparing proportionality with actual numbers.
Well, either proportionality
The number of people in
Yeah.
both the Netherlands and in Belgium has increased. In fact, I think in Belgium it's 500%. So it's the numbers, which is what's relevant here, have shot up.
No,
Is it?
I'm
Ray,
afraid
I'm going to stop you with
inventing
your
statistics on the
numbers.
spot. I know you need to invent statistics.
No, I haven't invented
No,
it.
no,
Yeah.
You're
Yeah.
angry when you make comments like that.
We've got-
You really do.
Yeah.
Can I just say we've got one more question. Lynn's going to answer a gentleman's one question that was made earlier on.
I
When
haven't
you
answered
answer that,
you yet. I mean, I haven't
I'm going to go back out.
thought all this through in detail, but I think my embryonic thoughts around this of taking an approach, having criteria, not unlike the DPP's approach, factors in favour of prosecution and factors against. And I think if I heard those sorts of sentiments expressed, would be, sorry, no, we need to look at this in a different way.
Right, I'm going to go back out again. Would you put your hands up if you've got a question? There's a gentleman there at the front, and there's some hands at the back. I'll take maybe 5 or 6. You, sir, go ahead.
I'd like to say thank you to all our friends because you've raised really fascinating arguments, and there's so many things I'd like to pick up on, and I'm only going to pick on 2. Peter said words to the effect of, why can we not let nature take its course? You did, actually.
Yeah, I did say it, yeah.
And the answer is quite
I didn't say
plain,
we-
because we ourselves have manipulated nature,
Yeah.
and therefore it is not possible for it to happen. I had a great aunt who I was very fond of, who in the end, towards the end of her life, was very ill and in great pain, and used to pray. She was a religious lady. She used to pray daily that God would take her. And so my father loudly remarked, kept popping the pills, which prevented him from doing so. So that's why we cannot let nature just take its course.
I didn't say why don't we, I completed
And
what you were
in
saying.
the same way, Kevin said, why is things different from the 1970s? And the answer is simply because our ability to extend life has increased so much. If we think about the NHS as a basket case. It's not a basket case at all, because by the measure, which is how long we keep people alive, you compare it with 1945, you compare it with now, and the answer is we have been immensely successful, and that has bred the problem that we're talking about. So we can't simply leave it to nature, because we ourselves are
I
nature's
didn't say that.
manipulators.
Okay, thanks. Thank you. We'll come back on all of these. And then, is that lady there with the red? Yeah?
Yes, I have 2 questions, and you will forgive my total ignorance.
Can you
Just a
speak
little
louder,
bit, yeah.
please?
Sorry, yes.
Sorry,
Stand Charles, fine.
I'm totally ignorant about the law, so this may be silly questions. But my first question is, if we do not allow assisted suicide, is this discriminatory against the disabled people? As far as I know, suicide is legal, so I can actually walk out of here and jump on your train. However, my mother cannot do that because she's paralyzed. So if we allow people like me to commit suicide and my mother is not allowed, is that discriminating against the disabled? And my second question is, this whole discussion seems to assume that I can't commit suicide. There seems to be a reason, there seems to be an assumption behind this, that somehow my body doesn't belong to me. I somehow assumed that, but legally, my body would be one of my properties. So, like, I can dispose of my house and dispose of my money, I can dispose of my body, and then suddenly realize that I do not actually seem to own my body.
Okay, thank you. Thanks. Good questions. Yeah, that gentleman there next to you.
I think one of the problems I'm having is that the panel are talking about so many different situations in which somebody may come to have an intervention leading to their death. And there are different factors which influence each situation. I mean, I think there's a difference between assisted suicide and assisted dying. And it seems to me one looks at it from the reverse and says, rather than cutting something short, is it right for doctors in certain situations to allow something to be prolonged? And if one looks at it that way, then my question would be, if one looks at it that way, is it right to prolong something? Is there a qualitative or moral difference between prolonging something through not prolonging something rather, through active intervention, or not prolonging it by holding back, and allowing people to die of starvation, for example? Is that qualitatively different from intervening to curtail their life? That's the question.
Thank you. Thanks. And at the back there, yeah.
Hi, I'm a little confused about it. There's so many.
Again, can you speak
Yeah,
up,
a little bit
please?
louder, please. Thank you.
I'm confused also. There's a lot of different issues. I think from Ray, you appear to be tackling it from a hospital-based point of view. That's your experience. You seem to be speaking about people that it's not something that's been coming a long time. It's perhaps they've been post-operative, they have problems, they've been in an accident, whatever. And you talk quite emotionally, and we're all human beings here, we understand your passion, and you talk about people being laid in hospital beds in their own fluids, in pain, and that should stop. But that's just a basic lack of care. That's really nothing to do with this situation. That's a different issue altogether, and I think you are confusing the two to try and make a point. To take it further, if we're talking beyond people that have had an accident and incapable of deciding something, or it's been something that's come suddenly, post-operatively, it's somebody that's been thinking for many months, even many years, that they wish to die, that's a completely different situation. Because those people have the ability to die. For whatever reason, as uncomfortable it is for us as human beings to accept, they have the ability, if they are physically capable, to engineer the situation without being too callous, of committing suicide. We have to ask, why do those people want to involve other autonomous human beings to kill them? Because let's not mistake, that is what we are talking about here. We are asking one probably small amount of autonomous human beings, as you call them, Ray, to insist, perhaps doctors against their will, perhaps, or other agents of the state, to kill them, even if it's by request. This is a very, very major step that humanity will take. As far as I understand it, I'm no historian, I'm just an ordinary working lad, but this could be the biggest mistake that people who are asking to legalise death could make in the history of humanity. I think we need to be careful what we wish for. And what amount of people are we talking about here? If we are talking about the people that are physically capable of committing suicide, if you like, forget that. In my opinion, that's dealt with. I've just dealt with that. If we're talking about people that are incapable, through physical disability or otherwise, to take their own life, what percentage of people is that we want to allow to enact this law that will affect us all? And of those people, how many do you think actually want to take their life? So we could actually be talking about an infinitesimally small amount of people that you want to change one of the biggest things that humanity's faced.
It's a very powerful question there. We've got one more. Yeah, we'll take one more and then we come back.
Yeah, I initially supported the right to die on the basis of that infinitesimally small number of people, because the image I had in my mind was someone who could only blink. It was only through blinking that they'd be able to choose to die. And for me, you know, I just thought, oh, that must be a terrible situation. But it's through listening to all the arguments and discussions that I've had to actually give it more thought. I have come to the conclusion that it is a bad idea. Obviously, just because I think it's a bad idea doesn't mean everyone should agree with it. But the point is, the question or point I want to make really is I'm slightly concerned if it's becoming a sort of political debate. Particularly, I was concerned that the scaremongering, it did sound like scaremongering from Peter, and the suspicion, or my worry, is that people will identify the argument against assisted suicide with a sort of formal religious approach, which basically says, you know, I've got this ethic of the right, the value of life, and therefore I just unthinkingly oppose assisted suicide. And some of your arguments just sounded like scaremongering.
Lots of good stuff.
Lots of good stuff.
Yes.
Kevin, come back on some of that. We'll work our way around and go to the next.
Okay, first of all, I'd really like Ray's definition. I'm ready for a Damascene conversion as well as Ray went through, if he answers this question. But so far, when he talked about autonomy, he said a little bit like a US judge talking about pornography. I can't define it, but I know what it is when I see it. And that is just not good enough to define between what's the difference between suicide of a 21-year-old who has the autonomy to decide and suicide of somebody over the age of 70.
Not good enough for me either.
Well, that's precisely what you said, Ray.
No, not at all.
The only other thing I would say, I think there's some really interesting questions out there. I think, first of all, the question about technology, expressed very well at the front, is actually wrong. Historically, it's wrong. And this is, you can go to my book and have a read of chapter 3, which is all about this very specific issue. There was an illusion that happened in 1970 that suddenly technology allowed us to live forever. And that this, of course, is a total illusion. People cannot live forever, and people have always, since medicine has begun, and particularly in the 20th century, have extended life using technological means. And it's only in 1970 and just beyond then that people started questioning that and saying, is this a good thing or not? But it's not because increasing numbers of people can live on and on in that sort of Frankenstein version of reality. In actual fact, technically, things have come a long way and it's getting much, much better. That's the good news, is that technology is helping us all live longer. In fact, Ray, in one of his excellent books, he does write some very good books, makes the point that it's much better to be elderly today than it was in the past. That in actual fact, the awful deaths are in the 60s, people who die in the 60s. And what if you can extend life beyond then, like for instance my father, who suffered from cancer twice, he's been saved from technology twice, and this is a great thing. And it's more our attitudes that changed. Very interesting question about if suicide is a right. Is it your body that you should possess your body? Of course, you should, and you do under the existing legislation, the 1961 Suicide Act. It does not make suicide legal. It makes suicide not illegal, which is a slightly different conception. And if you read the sort of discussion that happened at that time, they were very, very careful to say, we're not saying that suicide is a good thing, we are saying that it's ridiculous to prosecute it.
Yes.
So first of all, everybody has the right, if you want to, and it's not even worth thinking about as a right, because are you going to put somebody in prison when they commit suicide? No. Is that going to stop somebody?
No.
Hardly, unless they have a real reverence for the state. They're not going to really go, oh gosh, it's against the law. I'm not going to do it. You also have the ability to say, refuse all medical treatment, which is a way of ending your life if you want to come off of futile treatment. That is absolutely your right. So you do have all of those rights. And I think the gentleman in the back is right in that what we are asking here is to assist suicides. That is what is being proposed. There's nothing else that's on the table.
Ray, do you want to come back on any of those questions?
Yes. First of all, although I was a hospital doctor, my viewpoint isn't that of a hospital doctor. My viewpoint is that of a broad knowledge of people and how they die. And I want to tell you about my predecessor, who was chair of healthcare professionals for assisted dying. She was an internationally well-known GP, a wonderful woman called Anne McPherson, incredibly courageous, who had pancreatic cancer. For 3 years, she lived with her pancreatic cancer and put up with all the treatment, ghastly treatment she had, because she wanted to contribute to the world. She had all the best treatment. She had palliative care in Oxford. Her husband was a consultant. Her daughter was a consultant. There was no question of her. And she died at home. But the last 3 to 4 weeks of her life were absolutely bestial. And her daughter has described it in a brilliant and courageous article in BMJ. That's the kind of death that I'm concerned about. It's not about death by neglect. My God, as a professor of geriatric medicine, a geriatrician and somebody concerned with stroke care, I was very, very concerned about people lying in puddles of urine because they had bad nursing. That's not what it's about. It's actually about nature taking sometimes its horrible course. And we're always trying to defeat nature in its horrible course. Every time you take an antibiotic, you're trying to defeat nature in its horrible course. Every time you take paracetamol, you're trying to defeat nature in its horrible course. And as far as I'm concerned, if Mrs. Tallis had to go through what Anne McPherson went through, I would feel disgusted with myself that I hadn't protected her from it. And Mrs. Tallis would feel the same if I had to go through.
Right,
and by the way, one final point.
Yeah.
And it's not because she and I, who have loved each other for 40 years, don't value each other's lives, or we don't value the lives of dying people, or we don't value the lives of disabled people, or we don't value the lives of dying people. It's because we value our lives, and we don't want our lives actually to be then seen through the lens of a month or 6 months of your year of utterly disgusting, uncontrolled suffering.
But Ray, can I just push you to answer? I thought the question at the back, however, says, accepting all of that, is this not such a major step? And does this not turn everything, our relationship to each other, to doctors, to things that we've accepted?
I don't think it's a major step. I mean, basically we live in a world which disgusts me, where we murder people who don't want to die, where we actually don't care for people who are disabled, where there's lots of things that disgust me, and I think actually relieving the pain of people who are at end of life at their request by reducing their life is actually something positive. It's not a step into the darkness. My God, we're in such darkness. I am not at all illusioned about humanity, by the way. You know, I was born in 1946, the year after Auschwitz was exposed to the people. So I have no illusion about what humanity can do.
But again, is it not the case that you said that, you know, that by relieving pain we will shorten life? That already happens in a way. I mean, in terms of palliative care, in terms of looking after someone who's sick, it may be that the treatment may have an adverse effect on their recovery.
I'm the only
we
person on
make
this
those
panel who can answer that question from authority.
Yes, but this
Yeah.
is actually a decision to take someone's life, isn't it? This is different.
Well, no, when you switch off a ventilator, when you stop, I mean, Everett Koop, who was a Surgeon General in America, described switching off dialysis in a person who was terminally ill he called it euthanasia by death.
Okay.
There's a difference, though, in terms of if I am a
He didn't
doctor and
recognise that difference.
I stop futile treatment on a patient, that is not me killing that patient. Whereas
If you
me
switch off a
actually
ventilator, they will
taking
die in the next 5
action.
minutes.
Well, perhaps, but that's not me.
It's
If
also
I-
not illegal. That's the
No,
other thing.
precisely. It's available and doctors
Difference.
can use it.
If there's
But
distinction
it's
between
a
positive and
very
negative.
different moral act. It's a very, very
Correction.
different moral
Of
consequence.
course. We're going to answer some of these questions, and thanks for that. Very interesting. Lynn and Peter, who wants to go
After
first?
No, you're bursting. You're bursting.
If you
Peter.
like. Well, I'll just firstly just say that I mean I've got the Death with Dignity Act last year, 2012, in front of me. And in 1998, there were 16 people who died on the Death with Dignity Act. Last year was 77, and it's not a straight graph, just going straight like that. It doesn't
It's
have
because the
kinks
law
in
to
it,
be
but the number of
implemented.
people have increased. And if you are, can I just say, if you are going to try, I am totally aware of my fallibility as a human being. I could be wrong. But if you're going to try to correct me, do it with alternative statistics. Don't just assume mendacity in your opponent. It's uncharitable,
77
and it's
people
not
is
worthy of
0.2%.
you.
It took it
But
long
now-
for the law to get going.
As I
That's
say,
all.
assuming mendacity in your opponent is uncharitable, not worthy of you, sir. So can I just answer also some of the points here? Why not assisted death for disabled people? When you, again, as Kevin addressed here, I think he actually addressed most of these points.
We're not
But
talking
as he
about the
addressed,
death for disabled people, by the way.
No, but
No,
the
no,
lady,
she
the
asked
lady
us.
asked a
Yeah,
question.
she asked.
I'm absolutely not against it.
absolutely. Let's say it made it not illegal. It didn't legalise it. Even if you do have, as it were, a legal right to engage in something, it doesn't mean someone has the right to help you do it. And what we're talking about here is not the right to die. We have a right to die under the 1961 Suicide Act. What we don't have a right to is the right to be killed. That is the distinction. I think the guy at the very back was absolutely spot on in so much of what he said there. That's the distinction you have to think about. This is not the right to die. We have that right. It's the right to be killed that's being asked for, and that's very dangerous. Is this religious, as I pointed out? This doesn't, just because you agree with me on assisted death, if you do agree with me on assisted death, doesn't mean you have to agree with me on abortion or any number of other issues that have to do with the pro-life cause. I mean, I will agree with Raymond Tallis here. I'm the most consistent person here. I'm perfectly happy to say that in terms of the right to life. But you don't have to agree with me on abortion and embryonic stem cell research and all these other things to agree with me on assisted death. We can make those distinctions. This isn't inherently religious. And by the way, all the things that I've quoted are simply what's happened in other countries, particularly with regards to Oregon. I think it's reasonable to expect that if they've had particular problems with the system that they're running, that if we adopt that same kind of system, we're going to have similar kind of issues. That's not scaremongering, that's just pointing out what is happening in other countries. I'm very happy to share the sources for that. So I don't think we need to assume that if we go down this road, you're going to have to agree with all this other agenda that I may have. I think we have to make a distinction between these other issues and assisted death as an individual issue, because it is just an individual issue.
Thanks. Lynn.
Well, if I understood the lady, was she in? Yes, that lady. I think you were alluding to discrimination if you're actually not capable of committing suicide yourself, which I'm not sure. I might have missed a beat, but I mean, I actually think the law is incoherent and it is discriminatory, and then that's exactly the basis of Tony Nicholson's case, wasn't it? Because he wasn't capable of ending his own life, and his wife wasn't willing to assist in any way. So, and he was sort of pushing the law, and he actually wanted.
He did actually. He could actually refuse food, and he did, and he died 10 days after his.
But that's not a, yes, he did, but that is not what he wanted, and it's not a particularly
So it's the way
pleasant way to go.
Yeah, but it's the way to go. It's not to go, as it were. So
Yeah.
he did have the ability.
Okay, but he couldn't actually actively take steps to foreshorten his life quickly.
Sure.
Lost my thread now.
Sorry, I do beg your pardon.
It's all right. I mean, we know he wasn't successful, and I mean, what he was arguing for in this sort of very narrow band of cases, that such sort of mercy killing by doctors, they would be able to rely on the defence of necessity, and I think he's thought that there wouldn't be huge numbers in that. And Paul Lamb had picked up the case and he wasn't successful either. That would be one way of addressing the issue without legislation, I think. But the judges feel that this is such an important issue, we do actually need parliamentary intervention.
And who in this particular case would you say would be responsible for helping that person to commit suicide? Would that be a medical issue? I mean, it's not medical because they don't have a medical condition, but would doctors, in your view, is it doctors who would be brought in to help that person commit suicide? Or would there be some other non-medical person who could do it?
I think both possibilities are worth exploring. I mean, I suspect you're always going to have medical intervention. I think you need medical expertise.
I don't know, I think it raises an interesting point when it's not a medical problem, that whether you would expect medical professionals to help in assisted dying cases where the person actually isn't in need of medical treatment. They just feel their quality of life isn't.
But they have a medical problem. It seems to me that your doctor shouldn't desert you at your time of greatest need.
It's depression, though, Ray. This is it's a treatable problem that people are using. Now. Well, that's the reason why people opt for assisted suicides in Oregon. When we look at why did they take these steps, very understandable, but it's a treatable disease, depression, whereas the underlying physical condition that might be making somebody depressed is not.
But my point is actually that sometimes the condition might not even be a medical condition.
But the chances are most people, I wouldn't know. There's no evidence for this, but most people would need a prescription.
Yeah.
I think even if it's only at that level,
and it seems to be part of not deserting the patient, the therapeutic lines. Chairman, can I leap out just for a moment and come back again in 2 minutes' time? For a reason I'll explain. Yes.
Okay.
Thank you very
You
much.
might miss out.
Yes, I'm going. Thank you.
Okay. I wonder if it's an idea to go back out because we've got now. We've got about 15 minutes, I think, before we have to wind up, and that's just time to maybe take a few questions, more questions from the floor, and then when we've done that, I'm going to ask the panel really to give us maybe 2 minutes just to sort of wind up. So let's go. Any more questions there? Yeah.
I've just got a point about depression, which is when you talk about depression, there's irrational depression that's based on beliefs that someone might hold that don't fit in with the real world. If you're in terrible pain and you've got 3 weeks to live, then the depression you're having is not a maladaption, it's a perfectly sensible point of view.
Yeah.
But it is treatable.
Yeah.
No, it's not. No, it's treatable if what lies at the base of it are irrational beliefs.
But you can come out of that depression that you are feeling very understandable.
The whole point here is about assisted dying for people who are going to die. We're talking about terminal.
We're all going to die.
Yeah, but the point of this discussion is not about euthanasia. It's about people who want assisted dying, like people who are terminally ill. So this depression thing is irrelevant.
Why do these people want to die, though?
That
is the question.
They want to die because they're facing realistically a situation they're in. And it's realistic in the situation that a lot of these people in to feel hopeless because they have no hope.
You should have a look at Elizabeth Kubler-Ross, who writes very, very instructively on death and dying. And she makes the point that people go through phases. And they come out of the phase of being utterly and completely bereft, and they learn to look at the end of their lives. And that's why Elizabeth Kubler-Ross did not want a legalised assisted suicide. She's on the record as saying
that. We're talking about people who are in an acute condition right at the end of their lives.
Yes, I think that.
So the idea that what you're going to do is put them into cognitive behavioural therapy for a year isn't going to work.
If you have 6 months to live, you can't come out of it. You can't have a different
attitude. Can I take some more questions and then we'll come back? Maybe we can come back to this in the summing up. Yeah. Can we? Yeah. There's another question. There's a lady. No, there's a lady at the back, and then one at the front. Could you speak up a little bit? Maybe stand up a little. Could you just stand? Yeah, it's very difficult to hear at the front. Thank you.
Lots of doctors already do make life and death decisions. And is there an argument that this is effectively just rather than, because the problem seems to be that it's acceptable for it to be an omission, but for the issue is it being a positive step. Is there an argument that this is just another step along the progression of following on from the previous decision that you can have omissions which allow someone to die? This would just be a positive step. What's the difference between an omission and a positive step with regards to withdrawing treatment or giving treatment? And then the other issue I would like, that perhaps is slightly more focused for Peach and Lynn, would be regarding because I think we've got quite caught up in the moral issues, and obviously they are relevant, but one of the factors that you're considering is whether legislation would be a positive thing, whether further legislation in this area would help. And on that basis, I think there's an issue as to whose interest would legislation be in, and I think we focus very much on the patients who are the victims, arguably. But is there also an argument that legislation would provide more clarity and possibly assist society, or at least doctors or lawyers who are part of this system?
Thank you. Thanks. Yeah, well again.
Yeah, I think some of the last points feed into my COD theory anyway, to answer my own question of why this is kind of a debate today. To partly go over what Kevin said, we live longer and healthier than we've ever done before in human history, and now we've got a debate that started 40 years ago about how to end life. And I think if we look at this idea that people might be irreparably mentally damaged, for example, and therefore should have a right to end their life because they're depressed or whatever, or we look at, say, comments. I remember the deceased Labour MP Michael Meacher a few years back describing humanity as a pestilence on the face of the earth, or we look at the comments of David Attenborough recently about the problems of population, that the idea that the population is increasing is simply an apocalyptical, awful kind of idea. There's a real change in which humanity is viewed that is not healthy. There's a real basis to this debate that is deeply, deeply anti-humanist, that sees people as a problem that we should perhaps maybe think about getting rid of, rather than kind of promoting a kind of humanist view.
That's not true though. The reason that we're having this debate now and we didn't have it in the 60s is because basically there was a movement in the 60s about individualism, and it was spearheaded by the hippies, and the result of that is we now demand a lot more in terms of our individual rights and our to have our wishes respected than we did in the 60s. It's as simple as that. We're a much more individualistic society. We're much less happy being told what we've got to do and what we've got to accept, and that's why we're having the debate. It's not because of anti-humanism; it's because of individualism.
Well, the hippies are part of the problem of that anti-humanism. The hippies see everybody as greedy consumers and everything else, and they live a virtuous lifestyle.
I'm going to take just 2 more questions, and then I'm going to ask each of the speakers just to sum up and come back on anything they like. And there's some really interesting questions coming up from here, but I'm going to give them the freedom to choose whichever one they want to come back with to kind of sum up and make their final points. So let's have 2 more then. And I saw your hand went up again, so go on. Yeah.
Just on this question of why this is happening, I mean, I was thinking there is a tendency, if anything bad happens to somebody, that they start a campaign and it becomes a sort of reason to pursue a campaign to sort of change things in society. And perhaps it feeds into that. So, for example, if somebody's daughter has died in certain circumstances, that then generates the will to then pursue a campaign. And so perhaps there's that sort of tendency that's going on. But just one example of the consequences of legalisation, and just because there's this idea of which I accuse Peter of scaremongering, saying that you basically can't trust the doctors because once it becomes legalised, people just become under pressure to be bumped off. I think that's just
that wasn't my argument.
Okay, sorry, but the one of the consequences that I've experienced is my own grandma began to talk about she wanted to die, she wanted to go to Switzerland, and we had a very emotional discussion in a restaurant, and we said, Grandma, why are you talking about dying? You're not quitting life. Why are you talking about quitting life? And after that discussion, she decided to have a hip operation. She got out more, and she's actually rediscovered the will to live. And there's been no real discussion amongst recognition of the will to live as something that's a very personal, intimate, private issue.
Yeah, thank you. That's a great point too. We've got one more, so there's only one hand up, so to you.
I wanted to ask Ray, a personal question really, because you spoke movingly about how bad you felt about leaving a patient in these conditions. Why did you leave? Was it because it was illegal? Because that seems to me to be a fairly feeble answer, really, given how many people break the law for good reasons.
Okay, thank you. Now I'm going to give the speakers just a chance to sum up. And I think I'll try and impose some order here by asking them to do it in the reverse order that they all spoke, which means I'm going to start with you, Peter. Yeah. Okay.
So the question before us this evening was, should we legalise assisted dying? And I think the law, because this is a very much legal political question, the law exists for all of us. It exists so that, especially the most vulnerable, can be protected, but so that there can be a culture which leads to the flourishing of as all human beings, at least potentially, and certainly at the many of us. And when we try to change the law so that we can deal with this smallish group of very, very hard cases, and they are hard cases. If anyone goes away from here thinking that we just don't care about people like Tony Nichols and we don't feel compassion towards those people, let them be disabused of that. These are very hard cases, but hard cases make very bad law. And I actually really worry, given all the reasons that I've given, and I've seen no reasons really to refute the reasons that I've given in terms of the general effect it has on culture and medical culture, that this very anti-humanism, which I absolutely agree with you exists in our society, and particularly towards the vulnerable, which we have identified, that kind of anti-humanism is going to endanger the most vulnerable of us, and it could very much lead to the kind of consequences that we've seen in other countries. The one last thing I'll say is that I actually agree with you on the will to live. Surely we should be trying to create a society in which people aren't judged, or aren't judging themselves certainly, by what they can do. What they could do in the past, can't do now, whether or not they can achieve certain things, whether or not Terry Pratchett can write anymore. Judging people and having people judge themselves as inherently precious by virtue of the fact that they are loved and cherished human beings should be the culture we should be moving more into. I think that's more consistent with palliative care, and that's what we should be trying to encourage and move towards, rather than trying to solve the problem through assisted death. And so thank you very much for coming, and I hope that's what you all agree with.
Thank you. Lynn?
Well, not surprisingly, I can agree with part of that, because you've heard me say on a couple of occasions now about valuing people in society. And actually, Paul, I am almost offended by what you said a moment ago, because, I mean, I've fought in various ways for social justice, and my whole reason for being in many areas of my life is to sort of support vulnerable people and be their voice. And the fact that I actually support a small cohort of patients who wish to end their lives, I don't think detracts from that. And I think your grandma's story actually is just a practical example of the sorts of things that you were talking about. You know, that often if you reassure people that they're valued for what they are rather than for what they can do, you know, you would actually get rid of a whole swathe of people who are asking for suicide. But nevertheless, I do think there are some who require assistance. And the lady at the back, I mean, I couldn't hear you terribly well, but I think I agree with everything you said. Because I think the commission-omission debate, it's one that's hotly contested in academic papers, and it's weasel words on the parts of judges. You know, it's pure legal fudging, and it's unacceptable. And I think if we had legislation, there would be greater transparency, greater clarity. So, as you know, I mean, my focus tonight has been on having adequate safeguards, using the very best regulatory theory has to offer. I get somewhat irritated, I'm sorry, at this talk about, you know, what's gone wrong in Netherlands, Belgium, if it has, and Oregon. I think we need to look at the evidence more closely. My understanding is that the data from all these sources is somewhat suspect in some areas. But let's have a look at it. If it has led to certain untoward practices, let's learn from that. Let's look at what is the basis of that failure and make sure it doesn't happen here. And let's look at what is done well here, because there is a lot of good practice around that could be drawn into the regime that I'm anticipating could be used.
Yes, I mean, I am obviously questioning the case against, in favour of assisted suicide. So if I put questions in any of your minds, I've done my job. That's what I hope to be able to do. Because I recognise that I'm on the side of the debate that's counterintuitive to many, many people. But I do want to put some questions because I think it's a huge question. It's not just a matter of a few people. I think it is a real Rubicon. And I think it's a bit like capital punishment. You could justify capital punishment by saying, oh, just child murderers. We're just going to we're just going to kill those. We're not going to kill anybody else. We're going to try and restrict that. And then somebody turns around and says, oh, okay, what about pedophiles who do such and such? And you expand those categories. And this is what we can see is happening in the Netherlands, where they're expanding the categories to people over the age of 70. And there is a movement in Britain called the Society for Old Age Rational Suicide, which is also attempting to do this. So this isn't sort of, I'm not making this up. It's the sort of way it's working. It is a real Rubicon, and the person at the back expressed it quite well, that it's a very dramatic step when we allow the state to kill people, actively kill people who are just simply because their lives are wretched. I think that's a massive step, and it's something we should think very, very carefully about. Lots of interesting questions. The Emission Commission one, I just wanted to come back on. If I was saving a drowning man, and I could not make it to shore and let go of that drowning man, that would not be the same as me drowning that man. That's the Emission Commission. If I fail to save that particular man, that is not the same from my perspective. Maybe from the man's perspective, it's exactly the same result. But from my perspective, one act is morally worse than the other. And I think it's important to draw those kind of distinctions. So I would end on the most important question, which I don't think anybody can answer, which is that either you are providing assistance for every single person that asks for it, or you are defining people in a particular way to say your lives are so wretched that we will allow assisted suicide for this very special group. And this is what happens. This is why disabled people are opposed to assisted suicide, is simply because, in the main, because it is defining people according to these very physical characteristics. Sounds like incontinence is the one that everybody seems to agree with here, and that should be a basis, because people are incontinent, that they can have no dignity in their life, and I would very much protest that.
As someone who ran incontinence clinics for 25 years, I find that last statement absolutely disgraceful. I don't believe that incontinence is a reason for seeking assisted suicide. It's a reason for seeking help from somebody who runs an incontinence clinic and actually sort it out. So I have to say that's disgraceful. However, Mrs. Tallis and I have discussed assisted dying. I love her as much as I did 40 years ago when we first met. And if basically she was in absolute hell, I hope that there will be a law such as that she could be assisted to die, and by proper means, that it wouldn't have to be down to me to bump her off and then decide whether her carotid pulse has gone fat or not, and then have big booted policemen kicking open the door and deciding whether I as a medic should go into the slammer for 14 years. That's the reality of it. We are talking about real situations. We're not talking about discriminating against people. We're talking about people's valuation of their own lives in the context of all sorts of appalling problems when the outcome is inevitably death. It is not anti-humanist. You should be punished by reading the 500-page book I've written against anti-humanism called Enemies of Hope, because I am pro-humanist and I have written large quantities against anti-humanism. It's nothing about worrying about large numbers of people infesting the planet. It's about people individually making their own decisions that I've had enough. Many of you will be familiar with Bach, and there is a most wonderful Bach cantata called Ich habe genug. I've had enough. And that most moving one. And basically when a patient says Ich habe genug, I've had enough, that is the time when the doctor should not have to walk away from the patient and say, I'm sorry, I'm basically 14 years in the slammer. I'm speaking from the point of view of a doctor and of someone who is pro-humanist. I've written buckets of books, more than you could stand to read, supporting our humanity.
And that is punishment. I've had a look at it.
Exactly. So I have to say that it's all about respecting individuals' wishes in a very clearly defined situation at a time when they are in extremis. And I'm sorry to say, probably I'm influenced by my medical experience, but I sort of want to help people.
And on
There you
that
go.
note, can I say that we haben genug too? And we're going somewhere, we can go to somewhere quite nice, we can all go for a drink after this. I think some of us are going to the Veritas pub, I think, so I've heard. So if anyone wants to continue the conversation, then we can do that. And thank you so much. Can we give the panel a round of applause? I don't think we've resolved this.